Here we go. Okay, so Nephritis and cystitis. Speaking about Nephritis, it's considered as an upper urinary tract infection. Cystitis or urethritis, these are considered a lower urinary tract infection. These are super important. You need to be comfortable how to differentiate between them. Before reading anything, just stick with whatever written in red here. So if we speak about the cystitis and the urethritis, like the upper and the lower urinary tract infection. Well, the upper one tend to be much more serious than the lower one. Well, can you tell me please, in which one of the following you will have worse fever? Is it upper or lower? Just write one letter. Upper. The fever will be in the upper one, okay? Because I told you, upper one is much more serious, yeah? In which one you are going to have much more worse pain? Upper. It's still upper. Pain is upper. In which one you are going to have more systemic symptoms? Upper. It's also upper. Excellent. Okay, so you see, like fever, pain, everything is in upper. So what I have left to the lower? Well, lower, if you remember yesterday, we spoke about urinary urgency, yes? And I told you it's associated with UTI, yeah? And it's burning. It's not considered as a sharp pain, the lower one. Okay, so speaking about urgency incontinence, this is one of the most initial signs of the UTI, you know? And speaking of the UTI, well, it can be, if we say it's lower, it can be cystitis, which is an inflammation of the bladder itself. It could be also what? It can be as well this inflammation of the urethra. So we say urethritis, yeah? So the first thing that will happen that you can have an urgency, which is inability to hold your urine. So the patient will be running to the bathroom to go to the urine. Which we said in urgency, you have an overwhelming need to urinate, yeah? Well, can you tell me, guys, what is the most common cause of UTIs in a hospital? Why people in the hospital tend to get a lot of UTIs? Because of the catheter, urinary catheter. So you see, this is urinary catheterization. They put this catheter inside of the urethra all the way until it reaches the bladder. After it reaches the bladder, you must inflate a balloon. So that balloon prevented it from getting out. So you put it in, but it does not go out. So you are thinking, well, okay, so how can this lead to a UTI? It does not make sense. Well, you are putting a foreign material inside of it, which can precipitate to UTI. Plus, there is a stasis around it, yes? This stasis will also can precipitate to UTI. If you get a question, how to reduce the risk of UTI from such devices? And the answer one tells you, give a prophylactic antibiotic, okay? Prophylactic antibiotic. Answer two tells you, well, keep getting them out and in. So I mean just remove them and put them in every single day. The third answer tells you remove them as soon as they are not needed. Which of the following is the correct answer? 1, 2, 3. The correct answer is a 3. You must remove them according to the guidelines. The best prognosis is to remove them as soon as you can. When you don't need them, remove them right away, which means the moment the patient can walk on his legs. Okay. So, So, speaking about acute cystitis, is it lower or upper? Lower. Good. It's inflammation of urinary bladder, okay? It presents with suprapubic pain. Well, where is this suprapubic area? It's here. This is your pubis, so it's suprapubic pain. It's exactly right here. Okay, so they write, the patient will have dysuria, which is difficulty while urinating or disturbance of urination, urinary frequency. I told you, like they keep feeling like they want to go to the bathroom, and urgency. Basically, this is your body reaction to trying to kick out the bacteria outside, yeah? And you also, which systemic signs you can have? Tell me, please, which systemic sign can you have in case of... No, you cannot have fever. Systemic signs are usually absent. You don't have systemic signs, okay? This is how they love to trick you in the Usmle. There is no systemic sign in case of lower urinary tract infection, okay? You must master this thing. No high fever, no chills. Fever and chills are for lower or upper urinary tract infection. Is it for upper or lower? Upper, that's it, period. It's upper urinary tract infection, that's it. Good. So what is risk factors? Being a female, why? Because they have short urethra, okay? And sexual intercourse. Let me explain about this one because there is a whole disease we are going to speak about. It's called honeymoon disease. So this honeymoon disease, they like to give it to you on every single exam, actually. You will see it. I don't know if it's in first aid or not, but you must know about it. So let me explain it. Well, basically, if we speak about the GIT flora, GIT flora is mainly which type of bacteria it has. Which type of bacteria is in your colon? Yes, you have E. coli, which is a form of Enterobacteriaceae. So why I told you this weird word, Enterobacteriaceae? Because Enterobacteriaceae is most of the bacteria inside of your colon are Enterobacteriaceae, which include E. coli, it includes a lot of other ones. But E. coli is the most common. The reason I used Enterobacteriaceae, which is the name of the big family, is that sometimes on MCQs they give it. Okay? So you need to know the word Enterobacteriaceae, which is the big family, which contain E. coli. So you can imagine that during sexual intercourse, there might be going some E. coli from the anus, from the colon into the vagina, which can eventually lead to urethritis, cystitis. And here is the thing about UTI. They like to go up. So if you now have urethritis, if you come after a week, you don't treat it, it becomes cystitis. If you don't treat it, it will become what? Bial nephritis. See, it ascend, it go out. Okay, so before I continue, guys, if we speak about such patient, will they have white blood cells in their urine with acute cystitis? If a patient has acute cystitis, which is like inflammation, will they have white blood cells in the urine? Of course they will. Okay, now comes the tricky question. What about Bial nephritis? Will they have white blood cells? Yes, of course they will. Well, now comes the tricky question. Will people with acute cystitis have white blood cell casts? No. What about patient with Bial nephritis? Excellent. With Bial nephritis, they will have casts. So this is the way to differentiate, guys. Okay. So here they write, risk factors include female sex because of the short urethra, sexual intercourse because, yes, of course I can repeat. Look, you have an upper urinary tract infection and you have a lower urinary tract infection. If we speak about the upper urinary tract infection, we said it's like Bial nephritis. Bial nephritis has casts. Why? Because casts are forming inside of the tubules. And in Bial nephritis, you have affection of the tubules. While in case of cystitis, you do not have casts. And the reason you do not have casts because you do not have affection of the tubules. Yeah? Okay, I hope it makes sense. So lower urinary tract infection, they do not have cast. Only upper urinary tract infection has casts. Okay, so the next thing here they write is indwelling catheter because of the stasis. We just spoke about this. And the best way to reduce the risk is to remove it as early as possible. So this honeymoon urethritis I just described to you, if they ask you how to treat it, is teaching the patient about safe sexual hygiene, which means after each sexual intercourse, you tell the patient, after each sexual intercourse, tell the patient, look, after each sexual intercourse, you must go to the toilet and pee. Why she's being? Why urinating is helping her? Why do you think? Urinating is preventing her from getting a UTI. Exactly, you are washing the bacteria out. Okay, so you tell her after you finish sexual intercourse, go and pee. And there is one more thing actually you need to know about. You tell her, well, when you are in the bathroom, yeah, let's imagine this is our patient, and this is her head, her nose, to know what is anterior, what is posterior. You tell her when you use the toilet paper, go from the anterior side to the posterior side. Do not go from the posterior side to the anterior side. Okay, so speaking about which one has the cast and which one has no cast. White blood cells cast comes from the kidney, or they come from the kidney, yes? They come from the tubules. Remember, to have a cast, it has to be forming inside of the nephron, okay? Other way, there is no way you are going to form a cast if it's not coming from the tubules. As you can see, inside of the tubules, you have formation of the casts. So Bialonephritis is affecting your upper urinary tract. So the casts will form because it's affecting the nephron. Yes? Nephron is in your kidney. It's not in your bladder. Yeah? So thus, the cast will be in upper urinary tract infection, lower urinary tract infection, no cast. So I'm going to write here. Upper UTI equal two casts. Okay, so if we speak about lower urinary tract infection, there will be no casts. Okay, excellent. So next, let's see. Speaking about safe sexual hygiene, you tell him after finishing the sexual intercourse, you go when you are wiping, you use the tissue to wipe anteriorly to posteriorly, not posteriorly to anteriorly. You need to be really careful about this actually. Okay, because otherwise they will get the UTI. Good. So let's take a look. If they continue to have happens with them, even with doing all of the sexual hygiene correctly, you have to do something called postcoital antibiotic. What does the word postcoital mean, guys? Postcoital. There is word in English, actually in Latin, says postcoital. So what does postcoital mean? After sex, exactly. So after sex, they must take a pill of antibiotic. Okay, diabetes mellitus. Well, why diabetes mellitus lead to the UTI? In case of diabetes mellitus, we have sugar going inside of our urinary tract, yeah? So here is our kidney, you know. So we have sugar coming down from our kidney, and it's going down to our bladder. And inside of the bladder, we have some bacteria, like few bacteria there. Not so many, just a few. And when they see this glucose, be like, we have food, let's eat. So they are evil and they are super happy about it. They start eating the sugar, started forming colony, and starting leading to UTI. So people with diabetes mellitus have a really high risk of UTIs. Okay, impaired bladder emptying. Why would a patient have a poor bladder emptying? Many reasons. First one, diabetes mellitus. You're like, no. Diabetes mellitus is causing the sugar inside of the urine. Yeah, but it also leads to an impaired bladder emptying. Does anybody know why? Well, why diabetes lead to an impaired bladder emptying? Let's see. If you want a hint, it's related to the Schwann cells. Excellent. So the nerves coming into your the nerves coming into your kidney, let's imagine that these are the nerves, they will be kind of messed up from the diabetic neuropathy, yeah? So diabetic neuropathy will destroy the nervous system coming and controlling your bladder, your detrusor muscle. So your detrusor muscles become dysfunctional. When detrusor muscle become dysfunctional, it will not contract. No contraction equal to stasis. And an impaired what? Impaired bladder emptying, which will lead to, you guessed it, UTI. Yes? I hope it makes sense. Okay, let's speak about E. coli for a sec. It's the most common cause. And we said it's most commonly comes from where? Where does the E. coli comes from? Colon. Yep, comes from the GIT, from the colon. Okay, so also there is one more. It's called Staphylococcus sabrophyticus. Sabrophyticus. It's seen in cases of sexually active young ladies. E. coli is still the most common in this group. Yeah, they love to ask this question. Sexually active ladies, this is a nice way to say like basically prostitutes. And they will give it to you in the question. They will tell you that this lady who gets money in exchange for sex, and they will tell you that, okay, she's having a UTI. Which of the following is the microorganism that is causing it? Is it Staph sabrophyticus? Is it E. coli? Is it Klebsiella? Is it Proteusmirabilis? If you see that question, do not choose Staph sabrophyticus. Why? Because regardless of the fact that it's present in this population, E. coli is still the most common. They love to play you with that question, okay? So it's seen in sexually active women, but E. coli is still more common in this group, okay? So the next one is Klebsiella. Klebsiella is famous for having what? What does Klebsiella have that other bacteria don't have as good as it? She has. What Klebsiella has? Okay, that's true. What else? It has something really strong. A capsule, okay? Also, Proteusmirabilis. Proteusmirabilis has a tumbling motility. If you remember, we spoke about Proteusmirabilis and it caused one form of a stone. Does anybody know which type of stone does the Proteusmirabilis lead to? Well, of course it's a staghorn stone, but you need to be more specific because, you know, cystine stone can lead to a staghorn stone. And also the MAB, which is the magnesium ammonium phosphate can lead to stones. So which one is it? Is it the MAB or is it the cystine stone? It's the MAB, it's the magnesium ammonium phosphate, which is most commonly in a patient who have recurrent UTIs. Yep. Okay, Proteusmirabilis. So urine has ammonia saint, yes? And why? Because Proteusmirabilis is urease positive. And if we speak about an organism, wow, I keep forgetting about. Actually, you know what? I'm going to fix this now so I will not make this mistake again. Just a second. Let's make it not 2 pages and not continuous reading and 1 page instead. Thus, I cannot escape. I have to do every single one. Good. Okay, so moving backward. Yes. Okay, so speaking about this one, we have a Proteusmirabilis. So the Proteusmirabilis, as you can see, it's urease positive. And if we have urease positive organism, guys, urease positive organism, it will convert urea into ammonia, yes? And urea is converted into ammonia. What that will lead to the pH of the urine? Will the pH be higher or lower? Excellent, alkalosis of the urine. And that precipitate to which type of stones? Yep, excellent. So you get why the MAP happens. Okay, let's speak about the laboratory findings. So leukocyte esterase, which is made by white blood cells basically. And we said that in acute cystitis, we do have white blood cells. Guys, can you tell me, will we have fever in case of acute cystitis? What about chills? Maybe chills, we will have chills? No, no way. Exactly. No systemic symptoms, guys. No systemic symptoms. Not no symptoms. You will have this dysuria and urinary frequency and urgency, but no systemic symptoms. No fever, no chills, nothing like that. Okay. So leukocyte esterase will be positive because it's produced by the white blood cells. Nitrate will be positive, but I want you to be careful about nitrates. Nitrates will be positive only in case of Enterobacteriaceae. Okay? Why I'm telling you this? Well, if they tell you that a patient is leukocyte esterase positive, but she's nitrate negative, and she is sexually active lady, are you going to choose E. coli or Staph sabrophyticus? Exactly. That's the question. That's the question they put on the step 1. They tell you about, take a look, you have leukocyte esterase and you have the nitrates, yeah? And they are like, well, can you tell us please, this patient is positive for leukocyte esterase and she's negative for nitrates. So you must think, okay, it's totally bacterial. I know it's bacterial, so it must be one of these. But it's nitrate negative. Okay, so it cannot be E. coli. Let me take this one out. Well, I still have 3 left. How can I differentiate? Well, I just told you that it's in sexually active ladies, yeah? Sexually active ladies, we know that it can be E. coli. Next most common is Staph sabrophyticus. It cannot be E. coli because it's nitrate negative, so it must be Staphylococcus sabrophyticus. Okay, also there is something called sterile biuria, okay? Which means you have white blood cells, you have leukocyte esterase, but you do not have any bacteria in the urine. Well, that means what? It means that it's an organism that you cannot culture. So which organism you cannot culture? Well, it could be in case of erythritis secondary to gonorrhea or chlamydia. So gonorrhea, Neisseria gonorrhea and the chlamydia trachomatis can be transmitted by basically, well, it's a STI, sexually transmitted infection. And when it's transmitted, these diseases, you will not be able to see them on a gram stain most of the time, okay? It's really difficult to culture them. That's the idea. On a normal agar, you need a specialized agar to do that. Okay, you need actually, the agar you need to bring blood, burn it, make some chocolate out of it. Well, you know, when you burn the blood, it will burst, the red blood cells. They will get a lot of iron outside, which will you use to make the agar. Okay, that's for a different topic. That's for microbiology. We'll do it there. Okay, so let me give and the treatment with antibiotic, TMB, SMX, and nitrofurantoin. You need to be careful with which patient while giving this drug. Which patient, if he takes this drug, will have hemolysis basically. Well, sulfa allergy is pretty serious, that is correct, but there is also one more thing, G6PD deficiency. There is a disease called the glucose 6-phosphate dehydrogenase deficiency. When the patient has it, and you give him this drug, he will have what? He will have basically hemolysis. Hemolysis is a really serious condition. He can die because of that. Okay, speaking about these drugs, I want you to be careful about this thing. If we say TMB SMX, it works at the folic acid pathway. You need to know this, okay? Actually, in real practice, we do give TMB SMX most of the time. And do you know how many days do we prescribe it? Just because you are doctors and you are going to see this every day? How many days is TMB SMX for how many days? Well, actually, we give it for 3 until 7 days, but most likely 3 days. If you speak about nitrofurantoin, I will tell you my trick. How many letters is TMB? 3 letters, 3 days. Nitrofurantoin is 5 letters, the nitro. So it's 5 days, okay? So, okay, there is actually so many other drugs that you can give, but these are the most common. Okay. I hope acute cystitis made sense. Now we speak about Bial nephritis. Speaking about pyelonephritis, it has two types. So it has an acute one and it has a chronic one. I have a question though. Can acute cystitis become pyelonephritis? Yes, it can. They ascend. The bacteria be like, oh, well, sounds like Christmas. Let me go up. So they will go up and lead to pyelonephritis. They will just go up. Remember, it's an ascending infection. That's how they name it. Ascending infection. So it goes up. So acute pyelonephritis. Neutrophils infiltrate the renal interstitium. Okay, let's take a look at that. Okay, and if okay, you can see here. Oh, you cannot see shit. I hate when this verse they do this. Okay, the picture is bad, so I have to show it to you here. Okay. Oh, much better. Let's take a look. Okay, so you can see here, what is this structure? Just to get you oriented. What is this? This is structure. What is it? It's a glomerulus, correct. Okay, what about these? These are tubules. And you can see here many cells that have many nuclei inside of them. So this is acute inflammation. When you have many cells inside of the interstitium, this is acute inflammation, okay? So, multiple nuclei inside of them. Okay, so that's it for this one. Let's see. Neutrophils infiltrate the renal interstitium. They affect the cortex with relative sparing of the glomeruli and the vessels. Okay, so that's correct. We can see that they affect the tubules. They are filling the tubules basically. But the glomeruli look intact. The glomeruli are good. No touching of them. Okay. So they now write the following. They present with fever, flank pain. Oh, fever, systemic symptoms. And the flank pain, systemic symptoms. Well, serious flank pain, actually sharp pain. So, did we have fever in case of urethritis? Urethritis. No, no fever in lower urinary tract infection, including urethritis. Okay, so costovertebral angle tenderness. Let me show you where is this. It's between your ribs. Costo means rib, actually, guys. And vertebral means, oh, sorry, not costophrenic, costovertebral. Yep, it's this one. So, yeah, your kidney is right here. So you put your hand and you tap against your hand. Why you are not tapping directly, guys? Why we do not tap directly? Why we do not tap directly and we tap instead with, like, we put one hand and then we tap on the other hand? Well, in reality we do that because it's really painful sometimes. So you want to check if the patient actually has like any pain. And if he does not have a pain at all, you might use one hand. But initially you want to use two hands, so you will decrease the amount of the hit. So it will not be strong, you know? Because if it's really inflamed and you hit it with your hand, there is high chance, yes, posteriorly, you just hit it. Like, you hit it. So yeah, if he really has it, and you hit him strong with one hand, there is high chance he's going to sue you. So, okay, let's see the next one. Yeah, to check the costovertebral angle. Okay, so let's take a look at the next one. I know that I shit about this, but okay. So the next one goes something like this. Okay, we have now to speak about this. They have nausea, vomiting, chills, and fever. Nausea, vomiting, chills, and fever are systemic symptoms, which only are in case of upper UTI. Causes include ascending UTI. Yes, E. coli is the most common, like the lower urinary tract infection. Hematogenous spread to kidney. So that means that it can travel inside of your blood and goes to your kidney? Absolutely. Also, it presents with white blood cells in the urine. Plus or minus what white blood cell casts. So in this one, it's possible to have a cast. Why? Because it can involve what? Involvement of what lead to formation of casts? Tubules. The tubules. You have involvement of tubules. Remember, actually, acute pyelonephritis does not affect the glomerulus. You need to have affection of the tubules to have casts. Okay? So, okay. The next thing, CT would show a striated parenchyma enhancement. What? Well, enhancement means white. So you can see this is a kidney. This is a cross section of the kidney. And you can see white structure here, white structure there. So this is basically inflammation. Yes? Inflammation. Remember, one of the stuff that we spoke about in inflammation was tumor. Tumor was the edema. So if you have edema of the kidney at that area, you will have basically what? You will have enhancement of that structure. Let me show you. Pyelonephritis CT. Guys, what is better for inflammation, for visualizing inflammation? Is it a CT or MRI? See, this is the inflammation. Well, actually, it's an MRI, guys. It's an MRI. But which one is cheaper? Is it a CT or an MRI? CT, yep. CT is much more cheaper than an MRI. But MRI is much more accurate for inflammatory diseases, okay? For example, if someone has osteomyelitis, since the MRI is so specific for the inflammation, you will not even risk it. You will go directly to the MRI. Okay, so here we have CT show a striated parenchymal enhancement. So risk factor include, again, indwelling catheter, again, urinary tract obstruction, and again, no, not again, and vesico-urethral reflux. Guys, in this disease, vesico-urethral reflux, when we said that we had the bladder, if you remember, we said we had the bladder, and we spoke about the urethra. Were the urethra entering the bladder horizontally or obliquely in this disease? Horizontally, yeah, they were entering horizontally, and they had that horizontal insertion, as you said, this is correct. It lead to retrograde flow to be much more easier. Okay, and actually it's much less area of insertion compared to this one. Yeah, so that is also one of the causes why they have a retroflow. Also, diabetes mellitus. Why? Because, well, there will be a lot of sugar. But here is the one that is interesting. Why do you think, guys, pregnancy can lead to pyelonephritis? Can someone tell me? Pyelonephritis is due to pregnancy. Really interesting. Why do you think? Well, all of the causes are true, but there is one cause that is really, really important. This woman has a parasite. It's called a baby. So this pyelonephritis can happen because of a pregnancy, because you are compressing what? You can compress your ureter, yeah? So if you compress, notice, if we speak about, let me show you the ureter and, oh, here it is. Okay, so you can see the big baby, yeah? And the baby can compress the ureter. And when he compresses the ureter, he will lead to what? Stasis. And the stasis lead to what? UTI, yeah? Got it? So again, big baby lead to UTI. Yes, big baby compresses your ureter, lead you to get a UTI. Let me send you the baby. Okay. So that's why pregnancy can lead to UTI. So again, for the sake of completeness, big baby compresses the ureter. Ureter becomes staged with what? With bacteria inside of it. It goes back to the kidney and leads to UTI. Okay, so let's go back here. Guys, do you understand why pregnancy leads to UTI? It's actually important. I would like to stop for this one. Okay, good. The next one is, well, excellent question. Why not lower UTI? Well, the closure of the tube is happening here. So will the stasis be happening here or here? Will it be upper or lower? Upper. So the lower portion is actually intact. The compression is happening only at the ureter. Yeah? So the bladder and the lower urinary tract infection is intact. So it will not be inflamed, while the upper one will be inflamed. Oh yeah. Okay, good. So, but guys, keep in mind that this does not happen early in the pregnancy. It's like in the last trimester of the pregnancy. It's pretty late. Okay, so let's see. Complications include chronic pyelonephritis, in which we will speak about here. Renal papillary necrosis, in which we will speak about here. It will speak about here. Renal papillary necrosis, here it is. And what else? We have perinephritic abscess. This I will explain now, and Eurocepsis, which I will explain now. So, speaking about perinephric abscess, let's take a look at it. Well, if the patient is suffering from inflammation and this inflammation persists for a long time, it can be fibrous tissue will cover it. So it's an acute inflammation covered by basically fibrous tissue. In a more respectful way, we say it, what? Abscess. So it's a perinephric abscess. Let's take a look at perinephric abscess. Yep, it's something like this. So you can see the abscess. Well, but yeah, there's a better picture I want. Oh, here it is. See, perinephric abscess, but also I would like to show you a gross one. I hope I can find a gross one. I can see few, but they are not that good. Okay, this is good enough. Okay, you can see here to the outside perinephric abscess. It's outside of the parenchyma of the kidney. This kidney looks disgusting. Love it. Okay, so yeah, this one is good. This one is good. Let me send you this. Okay, so you can see this is the perinephric abscess. Okay, so let's go back to speak about this. Eurocepsis. Look, this is super important. Eurocepsis, we'll study it again when we do microbiology, but now we try to understand it, and then when we do microbiology, understand it again. Lower urinary tract infection versus upper urinary tract infection. Which one of them will have systemic symptoms? Okay, it's the upper one having systemic symptoms. So which one of them will have bacteria going to the bloodstream? Yep, the upper one. Since it's leading to systemic symptoms, that means that there is bacteria going to your bloodstream. If you have bacteria going to your bloodstream, you can have urosepsis. And why especially UTI? Remember, what is the most common cause of UTI? The most common cause of UTI, which bacteria? E. coli. Let me tell you something about E. coli. So E. coli, this Enterobacteriaceae, has a wall, and this wall is composed of lipopolysaccharide. Okay? Is it a gram-positive or negative? Negative. So it has a lipopolysaccharide. This lipopolysaccharide has lipid A, and actually let me tell you something about lipopolysaccharide, because I want to compose the whole idea for you guys. It has something called lipid A, it has some sugar, and has O antigen. These are irrelevant, but the important thing that it has this lipid A. So this lipid A work at what? it does something. It goes and activate what? The macrophages. You're like, what? Yes, it does. It goes from here, lead to increased release of interleukins, and these interleukins will activate the macrophages, and when the macrophages will be activated, voila, you will get what? Inflammatory reaction. Yes? Okay, so this is why, basically this is the mechanism a person got a Nobel Prize on in 2011, so that's why I'm explaining it for you. So lipopolysaccharide can lead to activation of some receptors, and these receptors in the macrophages will lead to release of interleukins, and these interleukins can lead to systemic symptoms, okay? So the patient will have an overall generalized inflammatory disorder in his body. So the lipopolysaccharide, when they attached into the macrophages, and after the release of this interleukins, you will have a massive vasodilatation, okay? If you have a massive vasodilatation, what is going to happen to your blood pressure? Massive vasodilatation, what happens to the blood pressure? It becomes really low. So if your blood pressure becomes really low, what is going to happen? Of course, regarding what exactly, but if you can tell me which point. Septic shock. Okay, so why septic shock occurs? So first of all, this gram-negative bacteria produce you lipopolysaccharide. Yes, this lipopolysaccharide has lipid A on them. This lipid A binds to a receptor on an immune cell, for example, a macrophage. This macrophage make you what? Cytokines, and these cytokines lead to an inflammatory response. That inflammatory response can lead to vasodilatation. Yes, and that vasodilatation, when it occurs, you will have hypotension. When you will have hypotension, so let me do it like this, okay? So we have gram-negative, it leads to what? LBS, lipopolysaccharide, which lead to what? Immune cells activation, which lead to what? Leads to cytokine making, and these lead to what? Basically immune response, and these lead to what? Vasodilatation, and that lead to what? Hypotension, and that lead to what? Shock, and that form of shock we call it septic shock. And when you have massive vasodilatation, what happens to your cardiac output, guys? Tell me, what happens to cardiac output? You have vasodilatation, it will be increased. Yes, reflex tachycardia. You have hypotension, your heart be like, I have to become tachycardic. Why? Because of the activation. So septic shock, activation of baroreceptors. Where are baroreceptors located, guys? Come on, come on, we are combining two systems now. Baroreceptors are located in the kidney, and what other organs has baroreceptors on them, which lead to regulation of your sympathetic activity? Come on, two other organs. Yes, the aortic arch, and what else? Aortic arch mediated by vagus and carotid. And the carotid one is mediated by which nerve? Yes, glossopharyngeal nerve. Excellent. And yeah, this one was vagus. Good. And if we speak about the glossopharyngeal nerve, these were activated now, and that will lead to what? Increased cardiac output, yeah? So high cardiac output. Good. So if you have vasodilatation now, so you have also vasodilatation, and that vasodilatation will lead to warm extremity or cold extremities. Vasodilatation, warm or cold? Warm, vasodilatation. Man, look, if your hand is inflamed, if your hand is cut and it's inflamed and you feel it, it will be warm or cold? It will be warm. Why? Because of the vasodilatation there. So vasodilatation make you warm area. So warm limbs. This is how you differentiate it from other types of shock. Here you go, guys. So this is all like we combined in this couple of sentences. We combined the nervous system, we combined the microbiology, we combined the cardiology and kidney. 4 system from the USMLE in one pathology. That's how you study for the USMLE. You need to combine all of the systems together. The more system we finish, the more easy it becomes. Also, immunology is here. I cannot wait to... Oh, by the way, according to your poll, the one I made, the next system for us is going to be immunology. Okay, so let's do this. Okay, so the next thing we are going to speak about is so that's Eurocepsis. I hope Eurocepsis makes sense. So the treatment is antibiotic. I hate when in first aid they write like stuff super simple. Eurocepsis, yeah, just lead to Eurocepsis. It's not that bad. And if you want to explain it, you have to write this. Okay, so if we speak about the antibiotic, in case of acute pyelonephritis, is it the same antibiotic as acute cystitis or it's different? Different, yes. So actually you need to know about this. You use a drug, which drug do we use? If someone knows which drug, that will be awesome. It's possible to use Vanco, but actually you can use, look, to be real with you, yeah, it's according to the culture, but most physicians are lazy, okay? So we just give ciprofloxacin and take a culture. Why? Because you do not want to wait for the culture to come, you know? So you give the ciprofloxacin, do the culture, and then you change the antibiotic according to the culture. Okay? So that's what you need to do. Okay. You give fluoroquinolones, then and do the culture. Then you wait for the result to come back. After the result come back, change the biotic according to the responsiveness of that antibiotic. Okay, good. Next. Chronic pyelonephritis. So chronic pyelonephritis goes as follow. The result of recurrent or inadequately treated episode of acute pyelonephritis. Like this person has acute pyelonephritis once, twice, thrice, he keeps having it. It typically requires predisposition to infection, such as having vesicoerythral reflux. Because why other than that, the patient will keep having this UTIs. So it could be due to this disease. Or a chronically obstructing stones. A patient having stones that are there and leading him to have a UTI, like a staghorn stone. In which disease do you have a staghorn stone in a child? Staghorn stone in a child. Remember, staghorn stone, there's two conditions that cause it. We have the cystine stone and we had the MAP. So MAP was recurrent UTIs, which take years to happen, years and years. So that will be in an adult. While the staghorn stones, if it was in a child, that will be cystinuria. Yeah? A genetic disease we are going to speak about when we do biochemistry. So coarse asymmetrical corticomedullary scarring in this patient with the blunted calyces. Speak about this in histological finding in a second. Tubules can contain eosinophilic casts resembling thyroid tissue, which we call thyroidization of the kidney. To start with this, the first thing I want you to know that the patient, when you look at their kidney, you will see a lot of scarring, poor tissue formation, and this weird proteinous-like material inside of the kidney. We call it thyroidization of the kidney. Let me show it to you. If you take a look at the histology of thyroid gland, see, what is this in the middle? This is what we call it. Does anybody know how do we call that? Colloid. So this empty areas, we call them colloid. Colloid, okay? And they normally contains like something called MIT and DIT, which make you your thyroid hormones, basically. Okay? So this is the thyroid histology. You're like, what the hell you are explaining renal, you stupid? It's not we're not speaking about endocrinology. I'm like, yeah, but wait a second. So if we speak about chronic pyelonephritis histology, quite interesting. When you look at the kidney, initially it will have what? Initially there will be some destruction. You can see that here they have some hyalination material. This one is really good because you can see the monocytes here, and when you see the monocytes, it means that the inflammation has been happening chronically. But if you see a neutrophils, it means that the inflammation is acute. Remember, acute is neutrophils, chronic is lymphocyte and macrophages. So mononuclear is chronic. Neutrophils is acute inflammation. Okay, so when that happens for so many years, what happens? The patient will start developing when this happens for so many years, your kidney will start to be like, well, this is weird, and we need to do something about it. What do we do? Nothing. Let the infection do its job. So infection lead to increased permeability of your vessel. So that increased permeability will lead to proteins passing from the blood cells inside of the tubules. Yeah? When these proteins move from the inside of the blood vessels to the inside of the tubule, they will start to accumulate. Their accumulation will lead to this. If you take a look at this, it looks like a histology of the thyroid, not the kidney. This is basically proteins that happened due to movement from the tubule, from the blood vessels to the tubules. Why? Because of chronic type of inflammation of the kidney. So pyelonephritis can lead to this. Okay, let's take a look at this. So there is also something called xanthogranulomatous pyelonephritis. Guys, there is a word in Latin says xantho. Whenever you see xantho, it means what? Yellow. Okay, it means yellow. Xantho means yellow. So xanthogranulomatous pyelonephritis. Well, if it says xantho, it's yellow. Let's take a look. What is that? Something yellow, I guess. Let's see. Is it yellow? Well, it says xantho. I don't know. Oh, surprise, surprise. It's yellow. Okay. So they write rare, grossly orange. It's yellow, not orange. Stupido. Orange nodules that can mimic tumor nodules. Okay. It's characterized by a widespread damage due to granulomatous tissue containing foamy macrophages. Why they happen? Well, basically there is a bacteria called the Proteus, and the Proteus vulgaris or Proteusmirabilis. Two types of bacteria, Proteus vulgaris and the Proteusmirabilis. These two bacteria, when they infect the kidney, and they are infecting it for a really long time, they start to form granulomas, kind of like TB. And when they form these granulomas, look what happens. See this yellow material? This yellow material, it's a granulomatous type of inflammation. Not inflammation, actually, necrosis. This necrosis will basically lead to what? To the death of the patient. But let me just send you this. It's because of infection. But the picture they show on the Usmle that I actually saw, and yeah, and you will see as well because they do ask about this. Let me send you. It's this one, and to be more exact, it was this one. Notice here, guys. See this basically CT. On this CT, you can see this cavities. Yeah, they might want to trick you about thinking about like polycystic kidney disease or something like that. In that disease, both kidney will be involved, not one. Look, this patient has a normal kidney and a bad kidney. So on his right side, it's a normal kidney. On the left side, he has this pathology. Okay, so, and that's it for UTI. I hope UTI made sense. UTI is really important. and you need to be comfortable with it, because yeah, you are going to deal with it every single day in your life. So you need to be comfortable with it, know how to diagnose it, how to treat it, how to deal with it, basically. Okay, now let's take a little break, comes back, speak about acute kidney injury, acute interstitial nephritis, and a couple of more pathology before getting another break. So for now, take 10 minutes break and see you in 10 minutes.